I'm Stella Wachepa, first year SHO. I will dwell mostly on prevention and prognosis. So it's always been said that prevention is better than cure. So we've seen all the complications of measles. So how can we prevent measles? And as the person speaking, introducing earlier said that prevention of measles is quite easy because it's via vaccination. So I'll take you through vaccination, infection control, post-exposure prophylaxis, and prognosis. So vaccination is the mainstay and most effective method of prevention. It is safe, effective, and inexpensive. It decreases measles transmission rates and also provides protection to unvaccinated individuals via herd immunity. So to disrupt broad transmission, herd immunity must be maintained between 85% to 95%. And in other countries, it said that the herd immunity should be maintained between 92% and 95%. As we've mentioned earlier, that measles is associated. Measles is associated by decreased childhood mortality from non-measles diseases and by preventing loss of memory cells that occurs with measles infection. So the measles infection itself, it decreases immunity by the loss of memory cells. So to prevent all this, vaccination helps us prevent all this. Sorry, I'm a bit nervous. So because there is a lot of reading in a short space of time. Okay, so immunization of measles. So the measles vaccine is found in three formulations. You can have the MMR, the MMR-RV, and monovalent formulations. And the formulation of the measles vaccine contains neomycin and gelatin. And also it needs to be stored in optimal conditions to avoid vaccine deactivation. So the measles vaccine is a live attenuated virus with an efficacy of 93% if one dose is given and 97% if 2 doses are given. And it confers long-term immunity. So the seroconversion rates are higher beyond 12 months. So as we know that children are born with passive immunity from their parents. So if it's given before 6 months, it's less effective. But as you go on, as the months go on, it becomes more effective. So the seroconversion rates at 9 months are 87%, at 12 months 95%, and 18 months 98%. So the measles vaccine, however, can still be given as early as 6 months. That's if in children that are born in areas of low transmission, that is in most of the Western countries. So if they're traveling to areas of high transmission, they can still be immunized and it will still be effective. However, delay of the first dose beyond the 12 to 15 months, it increases the duration of susceptibility to disease. So, and also, a second dose is always required. Children always respond to the second dose. So if you immunize a child, they may not always respond to the first immunization, but they will always respond to the second immunization. The third dose is not routinely given, but it can only be given during some outbreaks, but it does not confer any more protection against measles. So the WHO recommendation for vaccination, so it recommends that children should be vaccinated at 9 months in countries with ongoing measles transmission, so that's like countries, most African countries, and at 12 months in countries with low levels of transmission. So the 2 doses, it recommends that 2 doses of the measles vaccine should be given regardless of the formulation. So you can either give it as a monovalent formulation as MMR or MMRV, and should be standard in all immunization programs. So the second dose can be given as early as 28 days from the first dose of immunization, but should be given at most at 15 months of age. The WHO recommends that the vaccination coverage should be greater than 90%. There's no causal evidence between MMR and autism and autistic spectrum disorders. In the 2015 WHO report, so it was estimated that the worldwide coverage of the first dose of the measles vaccine was 85%. So this is worldwide data. So ranging from 74% in African region to 96% in Western Pacific regions. That's in 2015. So the global coverage of the second dose, while the giving of one dose has a higher coverage, the giving of the second dose has a lower coverage and only reaching 61%. That's in 2015. So among the estimated 20.8 million infants who did not receive the first dose of measles vaccine, only 53% of these actually came from the following countries. So they came from India, Nigeria, Pakistan, Ethiopia, and the DRC. So these are the countries that are not doing so well in terms of vaccination. So in Uganda, this poorly projects, but it's the immunization schedule, and it shows that Uganda gives a monovalent, the monovalent formulation of the vaccine, and it's given at 9 months, or whenever the child is in the first contact that the child has with healthcare after 9 months. This diagram shows us the coverage of measles vaccination in Uganda. So as you can see that I don't know if it projects so well, but it shows that the coverage of measles vaccination is between 70% and 80%. So what are the contraindications to vaccination, so that when mothers are asking you, you are able to guide them correctly? So severe allergic reaction to the previous dose or a vaccine component. And also in pregnancy and those attempting to become pregnant, it's also contraindicated. Also immunodeficiency. HIV infection in itself is not a contraindication, but those with severe immune suppression now cannot be vaccinated. So those with the CD4 count of less than 50%. Those with malignancies, so affecting the bone marrow and the lymphatic system, so those with leukemias and lymphomas, those taking systemic immunosuppressive therapy, and also those with primary immunodeficiency disorders. So in the second part, I'll be talking about infection control. So this is after exposure, how do we control the infection? So as we know that the measles virus is highly infectious, transmission is airborne. In aerosolized droplets, they can actually remain in the air 2 hours after the source has left. So to control measles infection, for example in hospitals, inpatient control is done by isolating the patient. So in immunocompetent patients, they should be isolated up to 4 days after the onset of the rash. But those that are immunocompromised, they should be isolated throughout the duration of the illness. In the outpatient setting, patients with febrile rash should be kept in separate waiting area. Both patients and staff should wear protective masks or respirators. Yeah, those are the requirements. So the general precautions: hand hygiene, so washing of hands before and after contact with the patient, use of gloves, gowns, and eye protection if at risk of exposure to blood or body secretions, the use of respiratory hygiene and cough etiquette, safe injection practices, and also the patients, it's best if they are kept in a room with negative pressure ventilation. So susceptible people should be excluded from work between 5 to 21 days of exposure. So a susceptible person is defined as a person who has never had measles, has never been vaccinated, or has no laboratory demonstration of immunity. So measles post-exposure prophylaxis. So this can alter the duration or the course of the disease. So on the post-exposure prophylaxis, it can be done by giving MMR vaccines within 72 hours of exposure. So this is mostly in infants greater than 6 months, and also, all the way through to adulthood. And the effectiveness of the post-exposure prophylaxis using the MMR vaccine is between 83 to 100%. But also, post-exposure prophylaxis can be given using immunoglobulin, which can be either IV or IM. And this is recommended in infants between 0 to 5 months of age, but also can be given in infants between 6 and 11 months. However, the MMR vaccine is preferred in those greater than 12 months, and the effectiveness of immunoglobulin is 69 to 100%. So post-exposure prophylaxis is using the immunoglobulin is recommended beyond 72 hours of exposure to less than 6 days. So it can only be given within the first 6 days. So what's recommended is catch-up immunizations to be given to children who lack appropriate evidence of immunity or whose MMR immunization status is not known. Prognosis of measles. So generally, measles has a good prognosis with occasional fatalities. The mortality rate is between 0.1 to 0.2%, but this was US data. The only study that I found that represented Uganda was during an outbreak in September 2015, where they reviewed 94 measles cases, and the case fatality rate in that paper showed that in those less than 5 years, the case fatality rate was 25%, which is higher than our statistics. So even though not a lot of people die from measles, the complications and the sequelae occur, and they include blindness in children. So in 2007, we had 197 deaths, and of these 197 deaths, 85% occurred in Africa and Southeast Asia. And the majority of deaths that occur in lower capita incomes and in places with weak health infrastructures. So the case fatality rates are high among children less than 5 years of age, and the highest fatality rates are between 4 months and 12 months, and also in immunosuppressed patients. So the complications that are likely to occur, in patients less than 5 years and in patients that are greater than 20 years. And morbidity and mortality are increased in patients with immunodeficiency disorders, malnutrition, vitamin A deficiency, and inadequate vaccination. And the common causes of death are croup, encephalitis, and pneumonia, and encephalitis has a mortality rate of 10%. Thank you.